Good day, friends, and a warm welcome to this episode of Season 3.0 of 4D. 4D stands for Detailed Discussion and Dialogue in Indian Diabetes. There should be a fifth D added as well, actually, which is dynamic, because our discussion and dialogue is detailed. It is about diabetes, but it's always dynamic. We keep on exploring, we keep on learning newer aspects of our wonderful subject. Now, if you want to have a dynamic discussion, then you need dynamic experts, is it not? So it's a great pleasure to be able to welcome three wonderful people, wonderful human beings, great friends, and also wonderful professionals. So a warm welcome to Dr. Mrinal Kanti Guha. Warm welcome, sir.
Yeah, good evening, everyone. Thank you very much for the welcome.
Dr. Mrinal has got qualifications in cardiology, internal medicine, and diabetology, and also a fellowship in diabetes management from CMC Vellore, and he now practices at Kolkata as a consultant diabetologist. Welcome, Dr. Mrinal.
Thank you.
We also have with us on the panel today Dr. Rakesh Sarkar. Dr. Rakesh is a cardiologist trained in cardiology and especially in electrophysiology, working at BM Birla Heart Research Center, Kolkata. Warm welcome, Dr. Rakesh.
Extremely thank you, sir, for your kind note of introduction. I'll be happy to contribute my opinion and thought.
Thank you. And the third person, our third musketeer for today is Dr. Tarak Chaudhary, nephrologist attached at IGPGMR SKM Hospital in Kolkata. Warm welcome, Dr. Tarak. I am reminded of this beautiful quote by Rabindranath Tagore, and he says that the beauty of a flower is lost if you pluck all its petals apart. So a flower is beautiful only if all the petals are together. But when we explore internal medicine today, what we feel is that, all the petals are being plucked apart. The cardiology petal is separate, the hepatology one separate, internal medicine separate, diabetes separate. So much so that our colleagues in nephrology, now they are planning to have separate petals, separate treatments for left kidney and right kidney. So, Dr. Tarak, what do you think about Rabindranath Tagore? First of all, it doesn't sound so beautiful in English. Could you say it in Bengali for us, if possible, any of the three of you? And what's your opinion about this quote and about the way general medicine or diabetes care is headed these days?
Yeah, this is really apt. What I would like to say is we are having branching, rebranching, almost every day. So naturally, we are breaking into different modes, different formulations. So I think it's been apt. I mean, literature with science mingled together. I mean, I think that great man thought about it maybe in a different way with a different perspective. But things are falling. Together at this point of time. As a matter of fact.
Even when I read Tagore, I actually feel that he is speaking to us, so many things where he connects science and literature together. For example, a group of essays that he had, a series of essays, the Vishwa Parichay, where he speaks about science. And this is before he fell ill. So he is actually able to put everything together. And I feel that actually he is speaking to us.
Actually, in our lives, he's omnipresent. I mean, he's present everywhere. I mean, in every sphere of our life, we can quote Tagore, we can remember Tagore, and he's with us all the time.
Dr. Rakesh, you are a cardiologist, and you must excuse us, people from across India. When I trained as a junior resident in medicine, for us, cardiology used to mean rheumatic heart disease. So that is what we used to study. That is what we were judged upon. And in my MD exam, I actually had a spotter, which was a CABG scar. It was so rare that our teachers put it up as a spotter. But rheumatic heart disease was rampant. Now what I see is, from a physician's perspective, we assume that the heart consists only of coronary arteries and nothing else. So all the discussion revolves around coronary arteries. We forget that there is a myocardium. We forget that there are, electrophysiological aspects of the heart. So any Tagore maximum, any Tagore quotation that comes to your mind, which talks to us about the beating of the heart. The beating of the heart is important. Otherwise, the coronary arteries won't function.
Absolutely, agree, sir. So basically, as you try to unfold the discussion with the example, it's a great example of the amalgamation of the different aspects of medicine. So if you look at either nephrology or diabetology or endocrinology, apology or cardiology. It's nothing but different facets of internal medicine only. And you must agree with the fact that, I mean, although we consider him as a great, a poet or a person from literature, I mean, Tagore has been, we call Rabindranath Tagore, who had been a kind of great philosopher, rather a teacher for, many decades. We have been with his literature and his remarkable creation. So, when I was trained in electrophysiology, let me tell you one thing. My mentor always used to say that never forget, although you will become an electrophysiologist, but never forget the art of medicine. So this is a mother subject, and you should always consider that although we are treating a person from our domain or genre of expertise, but we should not actually forget the person who has multiple organs, and together it is internal medicine. And that's why treating the person in a compartmentalized way is not actually the correct or holistic approach. Maybe it is something beyond your expertise, but whenever we are treating a patient, we need to have the comprehensive view and the approach to offer the best benefit. So that's why I also feel that at some point cardiology is also getting stuck, as you mentioned, some coronary artery disease, and lot of techniques which are evolved on giving the best benefit of opening the coronary arteries, like whether it is chronic total occlusion or deploying the stent with the best outcome. So everything is like a kind of technical revolution which are evolving, and it will also happen in next couple of years or decades. But nevertheless, we can't actually refuse the or deny the contribution of medicine, which are immense. And cardiology is not only of coronary artery disease, as you mentioned, because there are different elements in cardiology itself, like your muscle, like myocardium, valves, the understanding of the electrical function of the heart, and last but not the least, probably the coronary artery. And I must say, the last but not the least, that is even the pericardium of the heart has the role to consider about some of the cardiac diseases. So, cardiac, the science of cardiology is not limited to that particular, part or sub part only.
Thank you for putting this in perspective and this focus on teamwork. Because Rabindranath Tagore, he was a great advocate of collective, collaborative treatment. His work, his focus was on Samaj. Samaj means community, getting the entire community together. Dr. Tarak is with us. Dr. Tarak, the last few years of Rabindranath Tagore were not very pleasant for him. He was unwell. There is a lot of discussion on what he had. Maybe he had CA prostate. Maybe he did not have. But finally, the last few days were characterized by, I think, uremia. So he would have died perhaps of acute and chronic renal failure, maybe precipitated by sepsis. There was a post-renal component as well, multiple issues. And at least twice, the history is such that he would have gone into uremic encephalopathy for a long period of time. So all this, what does it tell us about the importance of the kidney? You feel that we are all guilty, maybe the people who are managing him at that time, we are all guilty of neglecting the kidneys. We are guilty of neglecting renal health. And it is just because because Bengali music, Hollywood music, they always talk about the heart is beating fast, the heart is beating strong. All the lovely singers in the movies are always talking to Rakesh Sarkar. So people forget the nephrologist, that we also have something to do in life.
Yes, definitely, sir.
So what comes to your mind? Do you feel that nephrology is a neglected subject when we think of teamwork, when we think of comprehensive management? Are things changing now?
Right now, it is changing because if there is any changes in EGFR or creatinine, or if there is any proteinuria, the doctors usually used to give referrals to us, particularly in acute and chronic kidney disease persons, or whether sepsis patients, where the patient presents with septic metabolic encephalopathy, where multidisciplinary treatments are needed. The referrals are increasing nowadays. It has become better than previously.
So things are improving. Dr. Mrinal, we've been talking about Tagore, but Tagore did remind us that if you want to cross the water, you're not going to achieve much by just looking at it. You actually have to get into a boat and then you have to cross. So in the diabetes care arena, are things changing? Are we just looking at controlling glucose, or do we actually try now to improve heart health, to improve kidney health? What is our target when we want to cross that ocean of diabetes?
So there's been a sea change you must be knowing. I mean, like, we don't target glucose any further. We are targeting, it should be a holistic approach, and our approach should be towards, mitigating the cardio-renal, vascular, and metabolic. I mean, I'd like to add liver to it also, all these complications. So while treating diabetes, while choosing treatment for them, I mean, nowadays we look for so many things, starting from weight to ASCVD presence, or association of other comorbidities. Because you see, nowadays, I mean, we rarely come across a typical garden variety diabetes case, mild diabetes with mild obesity. No, most of the time we come across patients coming in with maybe hypertension, maybe dyslipidemia, maybe a strong family history with history of smoking, alcohol consumption, etc. So it should be a holistic approach, and above all, because we didn't have a lot of medicines to target, to prevent cardiorenal metabolic complications. But now we have, a lot of medicines in our kit, armamentarium to target them, because, targeting glucose only might minimize the microvascular complications and maybe macrovascular complications to a little extent. But if you want to, target, all macrovascular complications, we should be very proactive. It's like, IPL will be starting up. It's like the first 5-6 years, like first 5-6 overs. First 5-6 years are very important. We need to target, because if you don't reach to the target within that short span of time, macrovascular complications also start creeping in. So we need to be holistic, and we need to use the new drugs that we have to prevent long-term complications, particularly cardio-renal and hepatic complications, and to initiate them as early as possible. So it's been a 360-degree change. I mean, previously we used to treat with only anti-diabetic medications. Now we start off with the medicines that are targeting, to mitigate long-term organ damages, isn't it? So it's been a, total shift, total paradigm shift.
Thank you so much. Like Dr. Mrinal has said, first of all, the target should be holistic, beyond glucose, metaglycemic. Then the technique, the tools that we use, we have better quality tools now. So we should use whatever tools we have, whatever best tools we have, which help not only in glucose control, but also in cardiac, renal, and hepatic health. And then the time, like he said, in the cricket matches, you have to put in lots of runs in the first few overs. That is the most important. A timely treatment, focusing on the right target, using the right tools and techniques. That is what is required. Dr. Sarkar, Tagore said that it is the dharma of the heart to keep on beating. The heart's dharma is to keep on beating, because the moment it stops, it doesn't live anymore. So, looking at it from a cardiac perspective, do you see more diabetes in your OPD? Do you see less diabetes? Do you feel that there is, we can impact choice of glucose-lowering therapy? We can impact choice of glucose-lowering therapy if we look from a cardiac perspective.
Yeah, so basically, there may be different patterns of patients who are presenting, or who have already presented with the symptoms of heart failure. So let me tell you, the meaning of heart failure doesn't define in the in the bracket of ejection fraction alone. It's a kind of standard, or must be telling that some diagnosis that should be changed by the physician or the doctor, not depending all the way on the ejection fraction echocardiography. And if you look at the profile of the patients who are presenting with heart failure, not necessarily all the patients will have, very depressed or reduced ejection fraction all the time. So in that case, people who will be presenting with heart failure, with diabetes, and some people who will be presenting with heart failure, and later they will be presenting or having.
Dr. Tarak, would you like to continue the discussion? Dr. Mrinal said that We need the right techniques, the right tools at the right time, and our target should be holistic. So let's look at it
Yes,
from a renal perspective. What targets do we want to achieve from a kidney perspective, and what tools do we have? Do we have new tools now in the oral glucose lowering therapy space?
yes. The modern evidence and guidelines indicates that early organ protection, particularly the kidney, and mechanism-based combination therapy are particularly important because the type 2 diabetes, heart failure, and CKD are the three part of an interdependent triad, where the CKD, chronic kidney disease, magnifies the heart failure morbidity and mortality, particularly by worsening the volume status, neurohormonal activation, particularly the RAS and the sympathetic nervous system activation, and uremic toxicity. Conversely, heart failure worsens the renal perfusion and causes nephron loss. The type 2 diabetes is the predominant driver for metabolic CKD and remains the single most important modifiable upstream factor for cardiorenal progression. Nephrologists are particularly uniquely positioned in between the endocrinologist or diabetologist and cardiologist because they can detect the early renal injury, particularly the albuminuria, which is indicator of systemic endothelial dysfunction, and also control the EGFR trajectory, particularly by promoting the renoprotective drugs and manage the drug dosage, and particularly the DPP4 inhibitors and GLP-1 and agonists, etc. And that can maximize the benefits and minimize the harm. So we have to choose the drugs particularly sequentially, and the different types of drugs that are available are AC inhibitor, ARB or ARNI, the SGLT2I and the non-steroidal MRA and GLP-1 agonist, and we have to select them from according to our the patient's profile and criteria.
So, Dr. Rakesh, coming to you, Dr. Mrinal mentioned that our targets should be holistic. Could you share with us what kind of targets do we need from a cardiac perspective? What should we aim for when we are managing diabetes?
Right. So whenever we are choosing or picking up the right molecule from the basket of the armamentarium, we should be always cognizant about the side effects and the kind of other organ protection or safety. So in that case, as Dr. Tarak also alluded that different neurohormonal stimulation which can perpetuate the heart failure milieu, or in the other way, the medicines which we are going to use for treating the heart failure, whether that can conversely affect the glycemic status. So these are the consideration while we are choosing the right molecule. And at the same time, the holistic approach is always the paramount importance for treating heart failure patients, because it is not only the heart which is failing, but it is also should be understood that there are different organs which are also involved with the the appropriate contraction and dilatation of the heart, and that's why the stimulation like rash activation or the endothelial dysfunction, which are interrelated components for involved in a vicious cycle. So in that case, medicines which are taking care of the diabetes and heart failure, and also renal safety is maintained. So these are extremely important to consider before we go for choosing the medicines, and it has the benefit in the it translates into the chemical benefit. So in that case, as you already know, that there are a couple of medicines in the armamentarium for treating the heart failure, starting from beta blocker, ARNI. ARNI is the new game changer, and along with that MRA and the SGLT2 inhibitors, and last but not the least, probably the Riociguat, which is going to be another new molecule in the basket. So among all these, probably the medicine which has got the shared benefit definitely is going to be the SGLT2 while we are talking about all these three components or the organ safety and organ protection. So maybe the other components regarding the renal protection and renal safety will be talked much about Dr. Tarak or Dr. Guha. Apart from that cardiac benefit, the other factors or the benefits they will be talking much, I believe.
Thanks. Dr. Mrinal, so see everything converging now, everything coming together. And Tagore reminds us that in the tapestry of life, we are all connected. So all the organs are connected, and the doctors, the healthcare professionals taking care of these organs, they are also connected. Each thread has its purpose. That is what Tagore says. And together, we create a beautiful picture. So now imagine a person in front of you. Can you say this in Bengali or in Hindi to the patient? So let's try to paraphrase, let's try to translate. So we say, Madam, in this tapestry of life, we are all connected, you and I. I am your humsafar, I am your travel companion. I am here to help you. Each thread has its purpose. So each medicine that we give you, each non-pharmacological therapy that we share has its own purpose. Together, they will all work together. You cannot say that I will choose the metformin and I will leave the sulfonylurea, or I will choose the dapagliflozin and leave the sitagliptin. All work together. Together, we create a beautiful picture. And that beautiful picture, madam, is your health, my health, the health of the entire society. So let's try to say that. See whether you would like to say it in English, Hindi, Bengali, Bhojpuri, whatever comes to your mind, sir. And then we move on with the same question to Dr. Rakesh and Dr. Tarak from a specific cardiac and renal perspective. So let's see how it sounds, sir. And let's see whether we can get the patients on that journey towards better health. Let's see if we can cross that sea together.
You see, Ramnath has always tried to unite everyone. So it can always be alluded to. And we know in Bengali, there is a saying called Amra Shobai Raja. So we all are kings, something of that sort. So, we can always equate that sort of, feeling or sort of, comprehension to our patients that, okay, you're suffering from this, so I could have suffered from this as well. And you see, all the organs are connected like the way we all are connected. You're here for a consultation, and I'm here to help you out. But of course, we are connected, and of course, mutually we can sort it out. So something of that sort, So we need to be united together, and we need to be collaborating together. That is how we can fix it up. So that's why. And as you were mentioning about the connection between different organs, as I'm also surprised sometimes to see which big is the other. Renal complications and cardiac complications. So which big is the other? Cardiac complications can reach to a renally complicated level, and it could be the other way around. So it's very difficult to assess all the time. Which one biggest the other. So that's why we're here to treat them holistically. We are trying to not to ignore any one of the complications, like be it dysglycemia, be it CKD or heart failure, or any of the phenotypes. Could be heart failure, or it could be ischemic heart disease, or overall atherosclerotic cardiovascular disease. So for different phenotypes, we need to choose agents, selectively, and we can sometimes combine them together. But whatever happens at the end of the day, we need to walk, again, I would like to use the term holistically. So you just cannot leave any one of them aside.
Thank you. Dr. Chaudhary, Dr. Meenal has shared this very beautifully with us. Now, this thread that binds us together, if we use different drugs for different organs, then the patient will end up saying, sir, I have got 206 bones. I have got 650 muscles. Does that mean I take 1,000 medicines? So the answer is no. You can give medicines which act on bone health or muscle health, and they act throughout the body. So can we use any single drug, and can we tell the patient that, madam, this is a thread, this is a drug which will give health to both your pancreas and to all the other extra pancreatic organs, including the kidneys?
The most important drug in our armamentarium is the LCA inhibitors. We always choose the drug first line, and we use the drug in the maximally tolerated doses, so that we can achieve the improvement in all the three organs, that is cardiac and nephrological point of view. If the albuminuria is still not controlled, then we usually add SGLT2I, and the drug which usually causes improvement in both the cardiac and nephrological improvement, as shown in the DAPA-CKD trial and EMPA-Kidney trial. And there is also cardiological benefit also that has been shown on the DAPA-HF trial. If after adding the SGLT2I, there is no there is still albuminuria persist after 3 months, then we usually add the non-steroidal MRS after critically looking at the potassium component, because there is chances of hyperkalemia when we combine non-steroidal non-steroidal MRA along with ACI inhibitors. So we usually checks potassium after 4 weeks, and if there is any increase in more than 5.5, then we usually hold the drug. But if the potassium level is less than 5.5, we usually continue. So the combination of the drug is particularly important, that is ACI inhibitors or ARBs or ARNIs according to the heart failure criteria, heart failure ejection fraction criteria. And after that, we usually add SGLT2 inhibitors, and after that, we use non-steroidal MRA or GLP-1 agonist according to the patient's criteria, patient statistics, patient's profile, particularly whether any atherosclerotic cardiovascular disease component is important or weight reduction is important. That's why.
Thanks. And like you rightly mentioned, we have to monitor patients, especially those with advanced CKD, for dyslipidemia. One advantage of dapagliflozin is that it reduces the risk of hyperkalemia. The second thing
Yes.
is that earlier, initially 10-15 years ago, we used to worry about dyslipidemia and think of hyponatremia. Now, actually, dapagliflozin is being studied for the treatment of SIAD, that is syndrome of inappropriate diuresis, and it is used to correct hyponatremia. So that is how science is evolving. But Dr. Rakesh, your comments from a cardiac perspective. Any oral glucose-lowering drug that can be accepted or that can be adapted for use in prevention and treatment for heart failure?
Yeah, surely. So, if I correctly understand your question, so maybe in that case, the drug which has the benefit in heart failure improvement along with the diabetes, so it's a preferred medicine just because not it is reducing the pill burden for diabetes, and at the same time it has the the benefit out of its class effect, means for which it was actually evolved or invented, or I would say that this medicine is having the benefit out of the its class effect. So basically it has been seen, if you consider about the ejection fraction, it is not only confined in the bracket of ejection fraction, the SGLT2, which already Dr. Tarak has mentioned, that its benefit is there with the improvement of heart failure, both in reduced ejection fraction group as well as in the preservation group, where actually it was mentioned as ejection fraction of more than 40% patients, which were included in the study, especially in the that study which were designed and almost comprising of more than 1,500 patients or 5,500 patients. So in those group of patients also it was shown that it has a definite CV benefit as well as the less number of hospitalization because of the heart failure, and it is shown that almost in the tune of 11% of CV death risk reduction, and almost 20 to 23% reduction in the heart failure hospitalization it confers to the patients, irrespective of the baseline medicines which they are getting, whether it is ARNI, beta blocker, and MRA or not. So this is a kind of medicine which definitely is a preferred drug, especially when we are considering the other medicines of diabetes and safety of the other organs like kidney and the endothelium of other organs. So basically, as you also mentioned, that it enhances the the sodium load also is getting reduced, although it has the propensity of having very minimal kind of, means some UTI or other things are also not very uncommon to see in those kind of patients. But ignoring all those adverse effects if you are little careful about the follow up. So basically, your benefit is much more than the adverse effects or the adverse outcomes.
So, thanks for pointing out the need for pharmacovigilance as well. But then, like Tagore reminds us, let me not pray to be sheltered from dangers. Let me not pray to be sheltered from danger. So dangers are a part and parcel of life, of human life. They are certainly a part and parcel of our life as physicians. We in general feel that we are the softest target in the world for everyone, all of us who are listening. But then we don't pray to be sheltered for them. We pray to be fearless while facing these dangers. So when you are facing a danger like heart failure, you act against it. And if, let us say, there is a potential danger of iatrogenic disease, then you act against that, be vigilant. So that is what Tagore is teaching us. So we use these drugs in the right manner with the proper stewardship. But all this brings us to a question, and Dr. Suneet Verma, who is a senior physician from Panchkula in Haryana, he says, sir, at the end of the talk, I would like to request all the three speakers, Dr. Mrinal, Dr. Rakesh, Dr. Tarak, to share their favorite Tagore quote, and that too in Bengali and English both. So that is a question coming for you, maybe in 10 minutes from now. Another comment coming from Hyderabad from Dr. Rakesh Sai to Dr. Mrinal and for Dr. Nitin Kapoor from CMC Vellore. He is president head of unit there. They say, sir, how do you view the combination of dapagliflozin and sitagliptin? Is the use of this combination, Dr. Mrinal, supported by guidelines for glucose lowering? That is a specific question.
Yeah, this is certainly a good combination. There is no denying the fact. Dapagliflozin, we know the mechanism of action, but there are certain. I mean, they can be combined together in a nice way because we know. I mean, when dapagliflozin causes glucose excretion, there is certainly rise in glucagon feedback to renal nerve, and you need to suppress this glucagon. Though, sitagliptin cannot do it to a great extent because they don't increase the level to supraphysiological level the way GLP-1 does, but it somehow blocks the suppresses the rise in glucagon, so there is good glucose homeostasis. And because since this glucagon rise, had it not been there, I think the dapagliflozin would have reduced glucose in a much better way. And if you there are also sayings like there are reports that though we don't have any RCT, if you to combine them together, there are less chances of getting genital mycotic infection. And both of them work together synergistically. They work in different, targeting different etiological. Both of them work in a glucose-independent manner. Very rare chances of development of hypoglycemia. Together, they reduce glucose to a great extent. And the pleiotropic benefits of SGLT2 inhibitors are remaining intact. They are neither getting attenuated nor exaggerated. So we get the same, pleiotropic benefits that we want to derive from dapagliflozin. So they all are intact there. We want to reduce the glucose load. What we are doing? If you want to add sitagliptin to dapagliflozin, we want to extract that little amount of, extra amount of, insulin from the beta cells that's still lying there. And on top of that, if you combine metformin with these, so we are targeting almost 7 out of those 8 minus octet pathological factors. So certainly it's a win-win situation. So you would always try to combine sitagliptin with dapagliflozin. If your patients are having HbA1c a little bit elevated, we know if it is more than 9%, we are free to combine 3 drugs. If it is more than 1.5%, then that of your target, what you have set for your patient, you're allowed to continue with dual drugs. And we are certainly going to use dapagliflozin for the patients who are having ASCVD, ASCVD risk factors, CHF or CKD as per the standard protocol. Even if the patient is having tight blood sugar level control, still the patient is not having any of the SGLT2 inhibitors. We can at least we can even substitute one particular molecule with this dapagliflozin. So it's a win-win combination. Side effects are getting negated. Overall effect in terms of glucose lowering and remaining, giving the patient benefit of about all the pleiotropic advantages of SGLT2 inhibitors. So it's a quite jolly well win-win combination.
So the diabetes guidelines, all of them say that SGLT2 inhibitors should be used in uncomplicated patients as well as those with complication or risk of complication like cardiac or renal. And when you combine sitagliptin and dapagliflozin, you actually reduce the risk of genital tract infections. But Dr. Rakesh, what do the cardiology guidelines tell us? Can you speak to us in two ways. First of all, the cardiology guidelines regarding CV risk reduction or use in coronary disease. And secondly, do we have separate guidelines which talk about SGLT2 inhibitors and atrial fibrillation? And then third would be heart failure. So can we take these separately, all three?
Yeah, so basically, American Heart Association has clearly mentioned the recommendation of using SGLT2 inhibitors uh, in the context of reduced ejection fraction subset as class 1 indication, and in the preservation class as class 2A indication. And as you, I'm glad that you have brought the question or the context that the atrial fibrillation and management of the heart failure, especially using the dapagliflozin or the SGLT2 other molecules. So it is clearly having the mechanistically benefit over the arrhythmia, because if you see that, I mean, if you introspect the mechanism of atrial fibrillation, apart from that RAS activation and other things which is quite common in the milieu of heart failure, there is another subset which predominantly found in the subgroup of OSA patients who are actually having lot of epicardial pad of fat in the epicardial part of the heart. Like this is something which has a lot of autocrine effects, and those fats are actually not the benign fats, as you can consider that these are the nidus for the triggers of atrial fibrillation, and these are actually getting deposited around the ganglionated plexus of the heart. So these are having a very complex interplay between the neuro and hormonal function, and triggering a lot of arrhythmia, which are again coming in a vicious cycle and perpetuating the heart failure status. So here also it has been seen in a few trials, although these are probably not randomized as far as my knowledge goes, but it has clearly shown that by various PET and MRI studies, that the epicardial pad of fat volume is getting reduced while we are using the molecule, whether it is dapagliflozin or empagliflozin, and it is also clinically translated in the benefit with the reduction of the arrhythmia burden. So definitely, this molecule is a kind of, not a kind of hype, but it has its mechanistic benefit, which is translating in the clinical outcome.
Thank you. So it is helpful. Dapagliflozin is helpful not only from a coronary artery perspective, which we all think of, but also from an electrophysiological perspective. Sir, we are all physicians gathered from across the country. Would you like to talk about, Dr. Rakesh, about atrial fibrillation and how we tend to underdiagnose it? As a physician, what can I do to ensure that I do not miss any atrial flutter? I will be able to pick up, but many times we miss many of the arrhythmias. So, what can we do to improve the quality of our service to our patients?
So actually, I'll tell you a very nice story that I came across, a couple of months back. So one famous singer of our country and definitely our state, he had a cardiac bypass surgery last year, and just before getting the discharge, means it was kind of 7th or 8th post-operative date of CABG. He suddenly developed one episode of atrial fibrillation, for which I was called, and I was asked to give my opinion. So as I was little more aware about that person, I just asked him about some of his past episodes and past history. That he had one history of TIA or maybe very minimal stroke. It was definitely ischemic stroke. I would say it was a CVA, not a TIA. And that time also it was not diagnosed. So this is something which is very interesting. Like you can have CVA, and later when you are actually taking care of your CV, that means the cardiovascular profile, like managing your weight and routine. Your health quality is getting improved by the comprehensive care, maybe hypertension, diabetes, your metabolic profile, everything is being taken care of. Now you discovered that you are having triple vessel disease, and when you are getting discharged after getting the CBG done, you suddenly discovered that all the things were revolving around something called atrial fibrillation. So atrial fibrillation is something which can be a very early, you know, predecessor of your or harbinger of your CV events. Like it could have been detected, or even the minimal fluctuation of your heartbeat, which could have been neglected initially, can actually give you the idea, or it can be a very good surrogate that you are actually suffering from some cardiovascular hazards, and you can be very much cognitive about that and careful about controlling your upcoming events. That's what I want to say.
Thank you. And we must highlight these aspects of health as well, because our patient will not go to you in different compartments, that I need my arrhythmia treated by somebody else and my diabetes and coronary artery disease treated by somebody else. As physician, we have to take care of all. Dr. Tarak, we have now in today's talk show, we have explored so many hidden aspects of diabetes care, hidden aspects of cardiac care as well, which we usually don't discuss. What about the kidney? What do the guidelines say regarding dapagliflozin in diabetic kidney disease? And what do they say regarding the use of DAPA in non-diabetic kidney disease?
It has been shown that the mechanism of the action of dapagliflozin is very unique. It usually acts by blocking the sodium-dependent glucose transporter, so it usually causes natriuresis and also decreases the intraglomerular pressure. As the sodium-dependent glucose transporter is not acting in the proximal tubule, it increases the oxygenation in the proximal tubule and also improves the myocardial energetics. It also thus it reduces the preload component of the heart, and by decreasing the neurohormonal activation, it decreases the afterload component of the heart. So it has been shown that in both diabetic kidney disease and non-diabetic kidney diseases, particularly, it helps in the reduction of all the mortality, both renal mortality, particularly the decline in EGFR or progression to the ESKD, or there is renal or cardiac death usually reduction occurs. Whenever we start the dapagliflozin, we usually ask the patients to monitor the creatinine. We usually say that there may be some dip in the creatinine, but it will be helpful in the long term. Up to usually we have to tolerate 30% reduction of the EGFR, or if it is present, then we usually continue the drug. We usually stop the drug when there is more than 30% increase in creatinine or EGFR, and or decrease in EGFR, or there is symptomatic hypotension or AKI usually occurs. So we have to monitor. In the DAPA CKD trials, it has been shown that it usually helps in the diabetic CKD population, but in EMPA kidney trial, it's shown that it helps in the both diabetic and non-diabetic population in reduction of the proteinuria or albuminuria, and improves the both cardiac and renal outcome.
Thanks. So, Dr. Minnal, we've had a great discussion. We've learned so many things about a supposedly single word, which is diabetes. Diabetes has got a total of, I think, 8 letters, but there is so much more to it than just hyperglycemia. We've also learned how we can use Rabindranath Tagore philosophy to integrate everything. We can use it to motivate our patient. And even I guess more important than that, we can use it to motivate ourselves to do a better job. But Dr. Minnal, would you like to put everything together in perspective, and we'll ask all of you? So 2 questions coming your way. First of all, what is your favorite quote? And what is one take home? Anything new that you have learned from today's talk show, sir?
Yes, I failed to get the first question. What is my favorite?
Rabindranath Tagore quote. Your favorite,
yeah.
Anything that inspires you.
I think you must have heard this, where the mind is without fear. This is one of my favorite, poems, and there are many others, but this is something really very good. But the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken up into fragments by narrow domestic walls, where words come out from the depth of truth, where tireless striving stretches its arms and towards perfection, where the clear stream of reason has not lost its way, and into the dreary desert and of dead habit, where the mind is led forward by the into the ever widening thought and action, into that heaven of freedom. My father led my country away. In Bengali, we start off with like chitto jetha bhoy shunno uchcho jetha shir. That means where the mind is held without fear and the head is held high. So this is one of my favorite poems by Tagore. And regarding unification that you were talking about in diabetes, our Janagana Mana was written by him. So he has taken us all together. I there cannot be anything beyond that. To make us united. So that's, I think, is the ultimate. I would like to say that, yeah. In the diabetes also, we have different components. Even we get diabetes patients at different levels of atherosclerotic cardiovascular disease load. So that's why we need to go for phenotyping them and treating them accordingly. We need to look for, we started off with triumvirate, then we reached to octet, and then egregious 11, dirty dozen, thirsty 13, and finally we have landed in sweetening 16 as far as my knowledge goes. So we have till that been able to accumulate at least 16 etiological causes that you need to target at, because it's certainly a heterogeneous disease. So we have this ramifications, this multiplications. But at the end of the day, we need to bring down blood glucose level. We need to bring down blood pressure. We need to tackle excessive lipids. We need to look for all the organ complications holistically. So this is how I look at it, because you need to, this is sort of conglomeration of thoughts. You just can't keep any one of them aside.
Thank you. And I think the philosophy of 4D is inspired by Rabindranath Tagore, because this is where we want to work without fear. We want to work for education without any boundaries. So
Yes.
thank you, Dr. Nehru, for putting things in context for us. Dr. Rakesh, which is your favorite quotation from Tagore? And how do you view the way forward? Anything that you've learned today?
Yeah, it was a great discussion. Contributed by all my colleagues along with you. It was great hosting, and I should say that a lot of unexplored part for me, at least. It was learned. Dr. Tarak, Dr. Guha, and as Dr. Kalra sir, you have been always a very good, moderator or rolling over the discussion. And I simply want to highlight one thing that the approach you mentioned in the context of the clinical practice, that it can't be always a kind of your own state or your single call. It has to be comprehensive and always a kind of team approach which you need to consider, even for treating a patient of heart failure, although it comes under your purview, but it is not always your concern that you will always try to cherish and nourish. Maybe somebody else can be very much instrumental in this context, although it appears to be heart failure, but a lot of other understanding is also involved in the treatment. And you should always you should be in the way that you should be flexible to take up the opinion of your colleagues, so that you can give the best benefit and best result to the patients. Thank you.
But Dr. Kalra, can I just say? But I think in the entire evening we have neglected one particular group of molecule, that is GLP-1 agonist. I don't know why. Maybe the discussion is about SGLT2 inhibitor, but they are no lesser than. If given a choice or chance, and if it is allowable, I would always like to combine SGLT2 inhibitor with GLP-1 agonist to prevent all sort of complications we're discussing tonight, because they can be clubbed together, different mechanism of actions, different pleiotropic benefits, and when given together, I think it give out maximum benefits in terms of cardiorenal metabolic protection.
That point is very well taken. Thank you. And like you said, it's about teamwork. All the molecules also work as a team, and each and every molecule has its own space, its own work. Dr. Tarek, when we speak of metabolism, usually excretion comes at the end. So the nephrologist has the final word always. So your comments, anything new that you learned today, and what is your favorite poem or quotation from Tagore?
Yes, it is a great discussion from learning from you all seniors, and it is a very great way of conducting and moderating the whole thing by Tagore's versions. It is a very well moderated session. The best dialogue from but the best quote from Rabindranath Tagore is that the highest education is that which does not merely give us information but makes our life in harmony with all the existence. That is, we must coordinate and work in such a way that the ultimate benefit is given to the patients, and we should be flexible in all the opinions given by all our colleagues, whether we should approach the patients and give particular medicine according to the patient's profile. That is particularly important. From the renal point of view, the new studies are coming which shows that we can give the SGLT2I dapagliflozin and the non-steroidal MRS up to 20, and we can also give that below 15, below 10 also. Because the new studies are ongoing, but it has not been published yet. So the benefits we have to see when the benefit outweighs the risk. That is particularly important, and we have to start the medications as early as possible, particularly when the patient's presents with EGFR of less than 60, that is CKD stage 3A or 3B. And whenever we start the medication early, the EGFR slope decline and the proteinuria decline is particularly predominant, and we can save the patient from progression to either ESKD or the major cardiovascular outcomes. So the starting the drug early is the most important thing, and here comes the role of the drugs that have multi organ role, particularly the SGLT2I inhibitors, non-steroidal MRAs, ACI inhibitors, GLP-1 analogs, etc. So we have to start the medication early, and we have to continue the medication as long as possible, up to when the benefit outweighs the risk. That's the most important thing.
So that is what we all take home from today's discussion, from our 4D detailed discussion and dialogue in diabetes. We have been inspired by Rabindranath Tagore, and we should continue to strive to live up to his ideals, what he expected from us. If we do our job, if we follow our dharma as a doctor, we do it to the best of our ability, automatically the best of results will be achieved. And I am very sure wherever he is, he will be very happy looking at us working. So that is one thing that we've all learned. Secondly, what we have learned from all our experts is that a timely intervention using the right tools, using the right tactics, and the term used by Dr. Tarak, that is multi-purpose drug, or a drug which has multiple actions. By Dr. Minal, multifactorial pathophysiology is addressed. And by Dr. Rakesh, multiple aspects of cardiac health are also addressed, not only coronary, but myocardial and electrophysiological as well. If we are able to achieve this with the right drugs at the right time in the right manner, then automatically we will get the right results. With this, I'd like to thank everyone for being part of 4D. Do remain tuned in. We are there with you every week. This is season 3.0 going on, and we are going strong. Thank you, Dr. Minal, for being with us. Thank you for your expertise. Thank you, Dr. Rakesh, for sharing your experience with us. And thank you, Dr. Tarak, for putting things in perspective for us. Thank you, everyone. We look forward to meeting you again next week. Jai Hind.
Thank you. Jai Hind.
Jai
Good night.